of this. Places like Paris and London, there's some famous pictures, in the London Tube Station or at the Louvre in Paris, that have done this out in the field. And this program began at the University of Minnesota, and the brainchild behind it was Dr. Dimitri Yiannopoulos and Dr. Jason Bartos. And they came together and basically have been trying to rewrite how we treat cardiac arrests, and in particular, refractory VFib cases out in the field. And what they found was that they had a massive increase in survival when they were placed on early ECMO versus standard ACLS. And this brought about the MMRC, or the Minnesota Mobile Resuscitation Consortium. And so we're going to watch a little video, it's about 10 minutes long, about where we are right now.
I don't hear the sound, Brendan. Did you optimize for video?
I did.
Okay, no sound.
I'm trying to see if I can put that on. I apologize, everyone. Yeah, I did optimize for sound. I'm not sure why it's not coming out there.
There's another little box at the top that says something about share computer audio.
Yeah, let's have a look. Yeah, it's not allowing me to.
Okay, you can either narrate it or move on.
Let me see here. Okay, so I'll kind of narrate it as we go, but this is our mobile ECMO truck. And this truck was designed around that device right there, and that's a mobile fluoroscopy arm. And this really is what you are needed to successfully do ECMO in the field, because cannula placement is the most important aspect of proper ECMO. You can do ECMO placement guided by ultrasound, but in order to really get a good placement of where those cannulas need to be, you really do need fluoroscopy. And what you'll see is we designed these outreach programs in the areas that we respond to, Fairview, South Bell being one. The university is the centralized kind of mothership, and then regions being our other satellite. They have these mobile C-arms that they'll bring in for our eCPR cases, and it is very, very important to have those in order for the patient to be successfully placed on ECMO. But this is showing you the truck, and it has basically everything that you need to do PCI. It's not rated for that. It's going to be, in my personal opinion, coming down the line, I'm sure at some point. To stent somebody for coronary vessel disease in the field is pretty incredible. But as you can see, we have everything we need in the ER. We have your ultrasound machine, the ECMO, the cardio help is down in the kind of right-hand corner. You've got your sweep and your blender up here on the right. And we do everything that you would do in an ER or in a cath lab here in the truck. And so this specific vehicle is housed at Edina Fire. It is manned by 2 fire medics. And then our ECMO team primarily is a interventional cardiologist, and an ECMO specialist, which is a flight clinician with lifelink 3. And this is just showing you kind of the back end of the truck. It is radioactively safe. I don't know if you can hear that. Can you hear that tone sound, Michelle? But this is the flow diagram, and there was audio that went with it, so I apologize about that, about the activation for the truck. And this is very, very heavily dependent on pre-hospital EMS, and I can't stress that enough. And as you can see, you can get a CPR activation 911 call. This is activated by EMS, who notifies our lifelink 3 dispatch center that there is an ECMO request coming in. And so the idea behind the truck is it rendezvous at a point to minimize time, because as we know, time is cardiac muscle, time is brain, time is everything. And if we can get these patients on ECMO within 60 minutes in the golden hour, would increase their survival exponentially. And so the truck is kind of at Edina Fire. Myself being the ECMO specialist and the doc, generally we're at the University of Minnesota, and the reason for that is it's centrally located. So if we get a call coming to regions, we're about 10-minute response time to regions, we're about 12-minute response time to Southdale. Obviously, traffic sometimes can be dependent on that, and weather can be a factor, especially during the winter months. But the idea is exactly that. We get a call, it's toned out.
Mobile ECMO, we have a request for you guys. 53-year-old male witnessed arrest shock times 2. Patients in VFib, 18 minutes out from Southdale. Mobile ECMO 99 has been activated.
And I don't know if you can hear that sound, but what will happen is the city of Edina Fire will respond.
ECMO 3 copy, show me now.
ECMO 3 will, oh, I apologize.
Male witness from Southdale. 3 copy, show me now.
ECMO 3, which is the ECMO specialist, will respond with Edina Fire. And then ECMO 99 will respond from Edina Fire as well. And as you can see, it is a very large truck, and you need a commercial driver's license, which was new to me at the time, to operate it, unless it is going code 3. And for those that are not in pre-hospital, code 3 is lights and sirens. But once it arrives, you will have the patient, hopefully the truck will be set up prior to the arrival of EMS. We will have 2 medics that will be inside and in full lead. They will then transfer the patient with active CPR ongoing. They will load them into the truck. We move them across onto the fluorosafe table. We then have Edina Fire will put the fluoroscopy arm into position, and then the sterile side will be the back end of the truck, as you can see, and the non-sterile side will be the front end, divided by the patient that is at a kind of a 45 to 60 degree angle there. And this was our first truck case that we had, and that patient, I believe, survived, and so did the second one. So this is an active CPR case ongoing. And the idea behind eCPR is exactly that. We want to continue good compressions. We want to have good ventilation. So for my pre-hospital folk, replacing that iGel or that King airway or your other supraglottic airway with a definitive airway is vitally important. Take the time to do that if you can. If you can't, I get it. A lot of times we discuss with our pre-hospital folk afterwards about things that they could do better. The biggest thing is removing the right pant leg and then placing a definitive airway. And so you can see active CPR is ongoing. The physician is accessing right femoral vein and femoral artery. They'll be placing guide wires up there, and then you will see a dilator kit that is coming in, and that's what those blue dilator kits are. And so in the bottom right-hand screen, you'll see the cardio help. It's on, but it's at no flow because it's not connected. The fluoro images at the top right. The ultrasound is in the center. You probably saw that before, which was enabling him to gain access to the vessel. You can see someone bagging. I can't tell if it's I believe this was an ET2, but there goes in the venous cannula. And what we use generally is a 25 French venous cannula, and it's normally a 15 to a 17 French arterial cannula. And I apologize that you can't hear the sound here, but this process of putting them on pump is generally very, very quick. We're normally on pump in about 4 to 6 minutes from the time the patient is moved over. That is one of the biggest differences between emergent ECMO and eCPR. There goes the red arterial cannula. They bleed out. So this process is pretty bloody. The circuit then comes across, and they'll cut into the sterile circuit here, exactly what they're doing. It's clamped on the pump side. As you can see at the bottom right, they're ramping up their RPMs. RPMs is just the speed at which the centrifugal pump is spinning, but it doesn't necessarily mean that there's flow because we're not connected, and we're also clamped. They'll do a wet-to-wet connection here as they're doing, so we don't want any bubbles. The clamps on the patient side are coming off. We're at 2000 RPM down at the bottom right.